Hello, everyone. We are back with the esteemed Dr. Shady Ashamalla, who is graciously presenting today on the surgical management of primary colorectal cancer. Dr. Ashamalla obtained his undergraduate honors degree from the University of Guelph in biomedical sciences, followed by a Master of Science degree at Queen's University. He then returned to Toronto and completed his medical degree at the University of Toronto. This was followed by a residency in general surgery, after which he went on to complete advanced training in minimally invasive surgery. He is with the surgical oncology team at Sunnybrook Health Sciences Center at the Odette Cancer Center, and his practice is completely devoted to lower gastrointestinal surgical oncology, with a focus on the advancement of minimally invasive technique within his field. Dr. Ashamalla also heads up a one-of-a-kind clinic at the Odette Cancer Center, the Young Adult Colorectal Cancer Clinic, which is dedicated, of course, to serving the needs of the under 50 patient population as they face the challenges and concerns related to a colorectal cancer diagnosis. As well, Dr. Ashamalla is a very valued member of CRAN's Medical and Scientific Advisory Board. So Dr. Ashamalla, a very warm welcome to you. I will pass it over to you for your presentation.
Thank you so much. It's great to be here. You guys can hear me okay?
Yes.
Okay, perfect. So thank you to everybody at CRAN. Thank you to Philomena for the invitation to speak. So I'm going to be talking today about the surgical management of colorectal cancer. And ultimately, surgery for colorectal cancer is an ever-evolving field. And, I titled it The Mystery of Surgical Innovation because there are principles of surgical innovation that sometimes are actually in contradiction with the oncologic principles of managing colorectal cancer. And I think it's extremely important to understand both sets of principles and then to marry the two together when appropriate. So that's kind of where my career has taken me. My fellowship after residency, I did a fellowship after residency or during residency, Andy Smith here at Sunnybrook said to me, we have too many surgical oncologists, which he was one, so he was talking about himself. We have too many surgical oncologists who don't do any minimally invasive surgery, and we have too many minimally invasive surgeons that don't know anything about surgical oncology. And so if you do both fellowships, we'll hire you at Sunnybrook and we'll change the world together. And that was really his vision, and I don't give a lot of talks where I don't give him full credit for that vision, because the goal was to really introduce a new field, and it was the field of minimally invasive colorectal oncology, which didn't exist prior. So what it meant was I ended up doing a fellowship first in minimally invasive surgery and learning how to be a technical surgeon with, at the time, laparoscopy and other advanced endoscopic stuff. And then doing a fellowship in surgical oncology, where none of my mentors in the second fellowship knew anything about minimally invasive surgery, but they knew everything about the cancer principles. And so ultimately, it was sort of two sets of mentors, and then the idea of mixing the two together. Today, a surgical resident would finish their residency. They don't need to do both fellowships, because if they do a fellowship with us, for example, at University of Toronto in surgical oncology, there's enough minimally invasive training that comes into it. But at that time, that wasn't the case. And so this was Andy's vision, but it's really, really important that anytime we're talking about the surgical management of colorectal cancer is to differentiate between the principles around oncology and the principles around minimally invasive surgery, because they are different and they both need to be adhered to. So just try to flip, there you go. So in the past, this was innovation. It would be a guy operating and a whole bunch of guys. I say guys because they're all men. Sitting in the audience looking over, and he's explaining what he's doing, and everybody's leaning in and super excited about the technique that he's employing. Obviously no sterile technique back then, but this is what surgical innovation looked like. Now it's not, critically different in a lot of ways. You can see, actually, if you look carefully in this picture, I think it's all still men in this picture, but it's the same idea, is that someone's doing something novel, everyone's around filming it on their iPhones, on their iPads, and is this how we introduce new innovation? And the answer obviously is no. This is not how we introduce new innovation. Innovation starts with advocacy in general. And I really like this slide. I use this slide for a lot of different talks, but this slide is extremely meaningful to me and very personal because, as you all know, this is Sunnybrook Health Sciences Center in the bottom right of the screen where I work. It's kind of the country's largest hospital, and I'm very, very proud that this started as a military hospital. It started with these advocates here at the top of the screen. And this was when our soldiers were coming home from the war, from World War II, and the mothers and wives and women of Toronto looked around Toronto and said, there is not a place good enough to treat our veterans. And at the time, there was the Christie Street Hospital, which was the only veteran center in Toronto. And these people advocated very strongly to William Lyon Mackenzie here on the bottom left that we needed a veterans hospital that was worthy of our veterans coming home from the war. And that was what advocacy was. And advocacy resulted in this bottom right picture, which became the country's sort of biggest and most important veterans hospital at the time. And it was worthy of our veterans coming home. And so the idea is that often it starts with marching up and down the street, waving a sign, beating a drum to try to get to a place that is worthy of what we're trying to do or trying to manage. And that really was how I feel about CRAN. That's how I feel about what Philomena and the entire team over there is doing. But that's how minimally invasive surgery was introduced. That's how laparoscopy was introduced. That's how all the different types of innovation are started by beating a drum and saying the status quo is not good enough. So that resulted in Sunnybrook Hospital opening up in 1948 as a veterans hospital, again, because the status quo wasn't good enough. So when we talk about what you're looking at there is a rectum after a rectal cancer operation. And the reason that's my first slide is because the most important principle around the surgical aspects of managing colorectal cancer are the oncologic principles. And the oncologic principles have to be adhered to. No one will ever thank you for a minimally invasive surgery or just little incisions instead of a big cut if you haven't taken their cancer out properly. And what's interesting is that this was the blessing and the curse, is because ultimately the surgical oncologic principles were what kept people from doing minimally invasive surgery for so long. This was the excuse used by way too many people for way too long. But the trouble was, it was the most valid excuse you could come up with. And what I mean by that is, if you don't do the appropriate cancer operation and the cancer principles aren't adhered to, no matter what you do minimally invasively, it's not helpful. And so for a very, very long time, and I'll talk about that, as these minimally invasive approaches were being introduced, the argument against them was always, well, we're going to breach those critical oncologic principles, and we have to do it open in order to achieve those principles. What slowly happened over time is we proved that you could adhere to those principles by doing the surgeries in a minimally invasive way when the right patient was chosen for the right operation. And I will talk about this later, but this is where it really becomes extremely important that the right doctors, the right specialists, the right tool belt is being worn by the surgeon such that they can pull out the right tool for the right case and not try to fit the wrong tool into the wrong tumor or the wrong patient. And when we make decisions around what operation is best, you need to have this breadth of laparoscopic, open, transanal TME, robotic, endoscopic. All of these different tools are in your tool belt so that you're not trying to fit a tool to a patient. You're trying to find the best tool for that specific patient. And then when we talk about how we make that decision, we use two factors. We use patient factors and tumor factors. So the patient and who the patient is as a person holistically plays in a huge way. And then obviously the tumor and the characteristics of the tumor and the size of the tumor and exactly its location play in as a factor. And using those two factors, we pull the right tool out of the tool belt. If you're a surgeon that doesn't do a lot of colorectal cancer, there's a good chance your tool belt's not quite diverse enough that you may not have that exact right tool, and now you're fitting the wrong tool to the patient. And that's really what we had been battling for a really, really long time in terms of the different approaches to managing colorectal cancer. So that's a really long preamble, but I do want to really focus on the fact that there are kind of two main principles. And the first, and I will talk about them separately. I'm going to talk about rectal cancer first because you're looking at a rectum here, and really what it looks like is just a like a tube of fat. And the reason it looks like a tube of fat is because the rectum's inside. I'm not sure if you can see my arrow, but you can see here there is the one staple line of the rectum, and the other staple line would be down here. The rectum is inside, and circumferentially around that rectum is what's called the mesorectum. And the mesorectum is the fat and the blood vessels that feed the rectum are all within that mesorectum, and it's filled with the lymph nodes that drain that rectum. And so the oncologic principles that were studied very carefully in the late 80s and early 90s were, in order to get the best results for rectal cancer, the lowest chance of local recurrence and the best chance of survival, a rectal cancer surgery needed to include a complete mesorectal excision. So what does that mean? It means that you can kind of see this shiny sheen here in this fat. It means that embryologically, it's the rectum and the mesorectum, and then there's this very thin plane, and if you look over here, this line right here, this very thin plane between the rest of the pelvic structures. And that's what needs to be adhered to. Prior, that plane was not adhered to. Prior to sort of understanding how important it was to excise the mesorectum, a lot of this fat was left behind. The rectum was removed, the tube was removed, but a lot of this mesorectum was left behind inside the patient. And you can imagine if this mesorectum has some lymph nodes, and those lymph nodes have cancer cells in them, and that's left in the patient's pelvis, that would eventually lead to recurrence. And so what it became very clear is, in order to do a proper rectal cancer operation, you needed to include this intact mesorectal excision. And that's this sort of shiny, cellophane-looking wrapped structure that includes all of the fat, all the lymph nodes, all the blood vessels that embryologically feed and drain the rectum. And so when we were in our evolutionary state, this was the hindgut. And the pelvis developed around the hindgut. And so when I remove a mesorectum, you could do it with a knife. You could do it with just very sort of sharp cautery, because there are no blood vessels that go from the pelvis into this mesorectum. It's an independent organ and so if it's removed intact like this, there's no sort of spread of lymphatics or blood vessels going into the rest of the pelvis. So the oncologic principle of a rectal cancer operation is that the rectal cancer is removed, the rectum is removed within the mesorectum, and the mesorectal envelope, which is what this is called, is complete. It's a complete mesorectal excision. And that means that all the lymph nodes and all the blood vessels are within, and there's not these huge divots of fat missing that are left behind in the pelvis. The other aspect is a margin. So the two areas around the margin are a distal margin, so the distance below the cancer of healthy rectum that's removed, and a circumferential radial margin, which is the distance around the cancer. And so in this picture here, you can see if this is the cancer. This is the tube. This is the mesorectum. This is the fat, the striated area here. Here's the rectal cancer. This distance from the lower edge of the cancer to the cut line is the distal margin. And this distance from the edge of the cancer to the border, the mesorectal border, is what's called our radial margin. And those obviously have to be negative, with a distal margin targeting 1 to 2 centimeters. So basically, that is the principle. You could talk about any which way of doing the operation, but that principle has to be adhered to. If you do it open, if you do it laparoscopic, if you do it robotic, however you do it, it needs to be a complete mesorectal excision. You need to have clear margins both distally and radially. And that is what's going to save your patient's life. So that is that's what sort of determines the oncologic outcomes, or the odds of oncologic success, much more so than the approach, whether you do it minimally invasive or robotic, or those are going to be quality of life factors, critically important. But ultimately, there is no quality of life if there's no life. And if you don't do this part right, then you could have, again, no real incisions and feel great 2 days after surgery and go home. But 8 months later, you're going to have a much higher chance of recurrence and subsequent death. And so the oncologic principles take precedent. And ultimately, what I was saying before is that that's what took so long for the uptake of minimally invasive surgery, is because the argument against it was, well, we can't compromise the oncologic outcomes, which is 1000% correct. But we've really shown now over the years that you can do all of these different minimally invasive approaches without compromising the oncologic outcome, as long as you are choosing the right patient and the right tumor. That's rectal cancer. For colon cancer, it's a little simpler, but it's the same principle in that for colon cancer, it needs to be the margin, the distal and proximal margin, so the distance on either side of the cancer needs to be a minimum of 5 centimeters on either side. So that is an oncologic principle. So a minimum of 5 centimeter margins, both proximal and distal, and a minimum of 12 lymph nodes. So the 12 lymph node story is only applicable to colon cancer. Cancer Care Ontario here in Ontario has kind of screwed that up in that they like to use 12 lymph nodes for both colon and rectum. It doesn't apply to rectal cancer. The intact mesorectal envelope is what applies to rectal cancer. In colon cancer, again, the mesorectum, and you'll see it in a video that I show, but the mesorectum is basically the fat that surrounds the colon. Again, blood vessels, lymph nodes are all living in that fat that surrounds the colon. And in that fat, we need to achieve at least 12 lymph nodes so that we can give a lymph node status. And you all know this, the staging. In order to stage a rectal cancer, if I remove that rectal cancer and I've only removed 3 lymph nodes adjacent to the rectal cancer, I can't say with confidence that is a lymph node negative cancer. Okay, I can't call it N1, N2, N0. I can't do that with only 3 lymph nodes to sample. The minimum number of lymph nodes is 12 to be able to say this is N0 or N1 or N2. At least 12 lymph nodes have to be sampled in order to have accurate lymph node staging. Accurate lymph node staging, as you know, is critical to determine what you're going to do next. In that patients who, the N0s, some of those patients we do give chemotherapy based on their T staging or based on other features. But if a patient's N1 has 1 or 2 lymph nodes out of their 12 had cancer cells in it, those patients need adjuvant systemic chemotherapy, and we don't know that if we don't sample enough lymph nodes. And so that's the oncologic principles for colon cancer: is a 5 centimeter margin on either side of the tumor in the colon and a minimum of 12 lymph nodes adjacent to the tumor. So that's the oncologic principles. And then from there, that's all that matters. So I will emphasize that is the critical importance. So as an advocate for a patient and for the patient themselves, their pathology report post-operatively is far more important than the incision on their abdomen, because it's their pathology report that's going to determine the likelihood that this cancer comes back or not. And for me as a surgeon, that pathology report is my report card. That tells me, did I or did I not do a good job? And sometimes, based on the anatomy, based on the cancer, based on the scenario, based on whether it's an emergency, and sometimes if a patient's bleeding to death and you're doing it faster than you normally would, et cetera, you may end up compromising some of those principles. But at the end of the day, that is your oncologic report card. And so I will look at the pathology report and say, great news, our margins were clear, we've got a good distal margin, a good proximal margin, it's far enough away, we have 17 lymph nodes and all of them were negative. Or we have 17 lymph nodes and 3 had cancer cells in them, so we know that you are a stage 3 cancer and that you require systemic chemotherapy. But the pathology report is the report card for the technical aspects of the oncologic principles. The patient and their family and their story sitting in clinic is the report card of the technical aspects, right? The patient has horrific pain, or has a bowel obstruction, or has a ventral hernia, or has a horrible wound infection. Those are your technical report cards. Obviously critically important to quality of life, but again, I will emphasize secondary to their pathologic outcome. And it's those secondary outcomes of the quality of life results, surgical results, that push or led to that surgical innovation. That was the placards and the drum beating, marching down the street saying, we got to do better. Okay, we get it. Those oncologic principles are critical. We got to get the rectum out with its mesorectum, but the way we're doing it and the extent of surgery and the footprint that we are leaving on this human being and their life and their quality of life, there's got to be a better way. And that's where the advent of all of these different approaches came from. And then the critical aspect of that is that you introduce an approach, you better be sure that you've proven beyond a shadow of a doubt that that approach is safe from an oncologic perspective. The right person's doing it, the training is correct, that the ultimate results of that technical aspect have not compromised the oncologic output. And that's very, very important. That has to be done in a rigorous, evidence-based way. Otherwise, again, you get super excited about these new bells and whistles, but you're leaving behind a poor oncologic output. So that is the really the very important background to surgery on the colon and the rectum. In terms of the actual operations, everything is dependent on location. So location of where the cancer is in this long tube will determine the operation that we do. And I can start with the rectum. If the cancer is involving the anal muscle, involving the sphincter complex, so if the rectal cancer, it's a rectal cancer, it starts in the rectum, but if it grows enough that it is touching or involving the anal muscle, the sphincter is sort of those skeletal muscle that's down that low. If it's touching that, and then those patients require an abdominal perineal resection. Those patients need to have the anus removed and the rectum removed, and the perineum, where the anus used to be, is closed completely, and those patients have what's called an abdominal perineal resection with a permanent colostomy. That is a necessary evil if that tumor is involving the sphincter, because even if you could get it out with clear margins, that patient will have no reasonable function. And I will say this to every patient, and I would, everyone should be repeating this to their patients, is no degree of incontinence a colostomy is infinitely better than any degree of incontinence. No degree of incontinence is worth it. So it's not about, oh, can I get the two ends back together? Like I can cut out just enough muscle here and I can make my new connection and it looks great and high fives in the operating room. If that patient is leaking stool and has no continence, it's a failure of the procedure. And so ultimately, I have never met a patient with a colostomy whose quality of life is worse than a patient that with incontinence. It's just, and I use these lines I use all the time in clinic. I'll use them this afternoon in clinic. If I walk into the room and you have a colostomy, I have no idea. I don't know what's there. I don't see it. I don't smell it. I have no clue. If I walk into the room and you are incontinent, I'll know the second I walk into that room, and you will know that I know, and that will lead to you not going out to restaurants, not going to the movies, not going to social events. Your quality of life is completely different, right? Whereas people with colostomies, they go golfing, they do everything. And so I really emphasize that. It's very, very difficult for patients to conceptualize a permanent colostomy, but I really, really push that narrative to make sure they understand that the permanent colostomy, it is an amputation. It's not very satisfying surgery to not leave the patient as they were when you got there, right? You are amputating an organ when you remove the anus. But ultimately, if the cancer is involving the anus sphincter, it's a necessary evil, and those patients will do far better than any degree of incontinence. A little bit higher up is certainly favorable in that we can cut on one side, cut on the other side, and bring the two ends back together. So this is a very good example. If the cancer is here in the mid-rectum, we would remove from the kind of the mid-sigmoid colon to the bottom of the rectum. That gets removed, and the sigmoid colon is brought and attached to the anus. And those patients, as long as their anal sphincter is intact, generally will have good function. I'm not going to say great, because the rectum, God gave us all a rectum for a reason. It's a reservoir. It has a job. And so when you have a rectal cancer, your rectum is removed. Your colon is being brought down into the pelvis as a prosthetic to do the job of the rectum. So it will not be normal, and it will not be what you're used to, but it often is very reasonable function. And again, I give this analogy all the time. If you had a cancer on your arm and I had to remove your arm and I put a prosthetic there, you don't expect that prosthetic to be just like your original arm. You expect the prosthetic to improve your quality of life than not having an arm at all. That is the same thing of the colon. When we remove the rectum, it is an organ, it has a function. We bring the colon down to do its job as a prosthetic. And we are doing that because we feel that that will give a better quality of life than a colostomy, in the same manner that a colostomy will give a better quality of life than any degree of incontinence, like we said. So that is a low anterior resection. And then a Hartmann procedure, not commonly used, but often done in patients who are very elderly, where a connection would be dangerous, where Again, you don't need to remove the anus because it's not that low, but you're not comfortable making the connection, in which case the sigmoid colon is brought up to the abdominal wall and created into a colostomy. Okay, so that's the surgery for rectal cancer. Every one of those operations is done laparoscopically, done robotically, and done open. And it completely depends on the extent of the cancer, where the cancer is located, and the patient factors. And every laparoscopic or robotic operation, when I consent the patient, I make sure they understand there is a risk of having to open the procedure. Why? Because if I feel that the oncologic principles are being compromised at any point in the operation, I reserve the right to open and do it with my hands as opposed to with the fancy instruments. And that's an extremely important principle that every patient, as they consent, needs to understand because, again, the oncologic principles take precedent. For colon cancer, again, location is the same. It is the determining factor. So there really only are sort of three main operations, and that is based on the blood supply. So what I mean by that is, and I won't go into too much detail, but the blood supply to the colon is very sort of anatomic. It doesn't change. And when we remove a part of the colon, we have to be certain that the two ends that we bring together have a very good, robust blood supply such that they will heal and the connection will not leak. And so whether a tumor is in the cecum or whether it's in the mid-ascending colon or whether it's at the hepatic flexure, the operation is a right hemicolectomy, which means transection in the mid-transverse colon and transection of the small bowel. This is removed. That is because the transverse colon has a very robust blood supply, as does the small intestine, and an ilio-transverse connection has a far, far better chance of healing well than if we were to, say, for example, attach the hepatic flexure to the cecum. Let's say the tumor was here. Why not just cut here and here? Because these two won't heal well together because of blood supply. And so anything on this right side is a right hemicolectomy. Anything on this left side is a left hemicolectomy. Anything within the sigmoid colon is a sigmoid resection. And then we're into the low anterior section of the rectum. Okay, so that's realistically, again, everything has exceptions. I operated on a 97-year-old a few weeks ago who had a tumor in her transverse colon, and I made a little incision, did not do it laparoscopically. I made a little incision just over her transverse colon. I brought it out. I cut a centimeter away from the tumor, a centimeter away from the tumor. I took no lymph nodes, no blood supply, and put the two ends together. Why? Because she's not going to get chemotherapy. I don't care about her stage. I want to make sure I get the tumor out, and I want to do it as quickly because anesthesia is a far bigger risk factor for that patient than a little incision. So that's why we didn't do it laparoscopically. And so very easy to look at that and go, well, that's open surgery. What's he doing? But it has to be tailored to your patient. In that patient, doing a 25-minute colon resection was far more important than doing a 2-hour laparoscopic resection. And we didn't need lymph nodes and we didn't need margins because her chance of recurrence at 97 years old is really not what we're thinking about. What we're thinking about is getting this tumor out of the way so it doesn't bleed or obstruct in the coming few years. And so, again, this is where tailoring the right surgery, tailoring the right procedure, there are patient factors and there are tumor factors, and they all have to be taken into account. So I think I've talked about this enough, but basically there's lots of good, strong evidence to say that hospital and surgeon volume are predictors of outcome. It is never wrong for a patient to say, how many of these do you do in a year? And I will say that for rectal cancer, it's not wrong for hernias. It's not wrong for someone taking out a gallbladder. Patients need to feel, and I think that's happening. I think that's where far less patriarchal medicine is happening in today's society, which is a good thing. But I think ultimately patients need to advocate for themselves and they need to say, I went to ChatGPT and it says very clearly that if you don't do at least 20 rectal cancers a year, your outcomes are different than people who do more than 20 a year. There is strong evidence that rectal cancer, hernias, gallbladder, whatever it is, but rectal cancer, because it is so advanced in terms of its technical aspects, we know that volume changes outcomes. And we know that these should be, and we knew, for Whipple's and pancreatic cancer, when I was a medical student, general surgeons did Whipples, and the mortality was about 10 to 12%. And over the time, it was sort of regulated, and you had to do a certain amount, and then you had to be whatever, and then you had to be certain certified. Now, only hepatobiliary surgeons do Whipple procedures for pancreatic cancer, and the mortality is less than 0.5%. It's like 0.3 to 0.5%. So think about how many lives were saved simply by deciding that this is a specialist operation, right? We have enough surgeons in this country, thankfully, and in this province that that we don't need our general surgeons to be doing advanced rectal cancer or pancreatic cancer. And if we do, and if we're in a province where that is a need, I think that's a bigger political issue that needs to be addressed, as opposed to sort of letting patients receive substandard care. So we know that hospital, and it's not just the surgeon, it's the whole system. It's the preoperative workup, it's the MRI that comes ahead of time, it's the nurse navigator that makes sure that somebody has discussed fertility with your patient, it's making sure that your 35-year-old woman that's about to get radiation for rectal cancer knows that she will go into menopause after this treatment, and there's a procedure where we can move her ovaries so she doesn't go into menopause. But how many centers do that? And so there are so many factors that are involved that this study done in 2002 in the Annals of Surgery, not in a small obscure paper coming out of Egypt, I say Egypt because I can make fun of Egypt because I'm Egyptian, but like this was a big study followed by many other big studies done now 25 years ago with zero action. We still have not centralized rectal cancer. And so my approach to this over my career has been exactly what, like me and Philomena, and I say this because we've been doing this together since I was a fellow 20 years ago, is to empower people to not necessarily wait for the systems to change, but to change themselves. So they should ask. They should ask very clearly, how many of these do you do? Or how many does your center do? Or, people, the algorithm for these disease, it's not that complicated. It really isn't, right? If you have one disease and you have to learn one algorithm, and quite frankly, AI gives a pretty good summary, it's not that complicated, and people should be empowered to understand that pathway and ask about it. Why didn't I get an MRI? I had rectal cancer. Isn't that standard for rectal cancer, right? Or is radiation being considered? Or these are the questions that I think have to be asked. So I could soapbox this forever, but I know I've got 10 minutes. So I will kind of give a bit of it's the same kind of, so laparoscopy 1990 to 2025. So the whole idea, same operation. In 2020, 30 years after the first laparoscopic colon resection was done, I put these numbers up because to me this is the real discussion around change. 30 years after the first right hemicolectomy was done, 60% of colon cancer was resected open. So only 40% was being done laparoscopically in 2020. And we're not talking about Sioux Lookout and, in the corners of the province where there's just not enough resource. You could go 10 minutes in one direction or 10 minutes in another direction or 10 minutes south down towards the lake and get your operation done open. In 2020, 60% was done open, and 70% of rectal cancer was done open 30 years after the invention of laparoscopy. And then you'll say, okay, well, what about those oncologic principles? The trials that proved oncologic equivalence in the right hands for colon and rectal cancer were completed by 2000. After 2000, it was redundant to do a trial showing equivalence of oncologic outcomes in laparoscopy. So if I did a really fancy trial in 2010 about rectal cancer, laparoscopic versus open, it wouldn't get published because it would have said this is old. Like, we know this. We know it's equivalent. And yet, look at the rate of change, right? And so this is where patients' self-advocacy and advocacy groups are so critical to ensure that these patients are being treated in the right place, in the right way, and that they're pushing and saying, well, do you do this laparoscopically? And I love that question. And I love it even more when I can say, yes, but in your case, it's not the right thing to do, and this is why, right? And I have that conversation, especially in a tertiary care center where I'm doing a lot of these huge recurrent cancer. I can't do it laparoscopically. But the fact is the patient is right to ask. They should ask, and I should have a very good explanation as to why I'm not doing it laparoscopically. And that explanation can't be that's not how I do it, just to be clear. Okay, so I'm going to show really quickly. I'm going to skip ahead a little bit. This is a laparoscopic right hemicolectomy. It's a little bit hard to follow without, but so I do want to just show the connection. So here we are here. This is, as we talked about, the small bowel is on the left of the screen. This is the small intestine. This is the transverse colon. A stapler is placed between the two. Goes really quick. And then we sew it close. So we're connecting. We've removed the right side of the colon, and we're connecting the right, the transverse colon to the small intestine. And this is us sewing laparoscopically. And I like this video for non-surgeons. I like showing this video because I like sort of demonstrating when you sew, this is what our hands look like. This is the dexterity we have laparoscopically. So you can see this is me suturing, and this video was from maybe a decade ago or so. But the suturing is really no different laparoscopically than it is open. It looks extremely similar to if I was to be suturing with an open needle driver and doing this as an open operation. You can see those are my two hands functioning. These are long instruments with a camera looking inside the abdomen, and we're tying a knot there, and we're bringing the small bowel to the transverse colon and making this connection. Again, I'm not showing this because you need to, and those are the incisions following that right hemicolectomy. I'm not showing this to, it's not a how-to video, but it's more of a demonstration of sort of how the hands work as we do this laparoscopically and what we're capable of doing laparoscopically just with the camera. So that's the right hemi. This was another huge advent, and I do want to sort of talk about this quickly because I think this is another very, very important aspect of surgical management. And that's the understanding that not every endoscopically unresectable rectal lesion requires laparoscopic low anterior resection. So what do I mean by that? In the past, you saw I showed you sort of on the diagram where a midrectal cancer would be. We know that those lesions that are precancerous or that are even T1 in nature, so very early stage rectal cancer, do not require a low anterior section. They don't require the entire rectum to be removed. Oncologically, it is very logically sound to just resect the lesion itself, to just cut it out and close the hole from the inside. But that really wasn't possible to do open. You can't reach inside, like in an open fashion, you can't reach inside someone's rectum and just cut out the early stage rectal cancer. And so those patients, when I was a trainee, they were all getting low anterior sections. They were all having their rectum removed. As soon as it wasn't resectable with the colonoscope endoscopically, it required a low anterior resection. That changed with the introduction of TAMIS, transanal minimally invasive surgery. So TAMIS is inserting a port through the anus, it sits, this is the anus, you can't see the anus because the port's sitting there. You blow air into this port here, and then you have these two working hands. And now that gives you a window into operating in the rectum laparoscopically with the camera, and you can go as far in as you want. That's reasonable. So this is us. These are the patient's legs. This is the anus. The port is in place. The camera's in place, and we're looking into the rectum here, and we can operate through those two hands to do the procedure. So this is an example. This is I'll show you the patient in a minute. This is, Philomena knows this, and this is all with Mike's permission, but this is Mike Calderon's rectum. And Philomena, you remember Mike Calderon? You do? Yeah. So this is Mike's rectal cancer. And so Mike is a good story and may even be my closing story. Mike was seen in an outside hospital. He had rectal bleeding. They conducted a colonoscope. They identified a rectal cancer. And they planned to do, because it was sort of mid-rectum, they planned to do a low anterior section and remove his rectum. The idea was they were going to do a Hartmann procedure. He was going to have a stoma for a period of time, and then he would be reconstructed. I can't remember exactly how he came to us. I don't know if it was him. More than likely it was Phil. But like he came to us. It was him. He came to us, and he wanted a second opinion. And we did it. We did a scope. I said, that looks like an early cancer. We did a transrectal ultrasound, which tells us better than an MRI, whether it's a T1 or a T2 or a T3, which determines, and I'm really what I'm saying, the translation of what I'm saying is not you need to know any of this stuff. It's how complicated this can be and how many options there can be based on these findings. So we did the truss. And the transrectal ultrasound came back and said it's a T1 rectal cancer. And as a T1 rectal cancer, local excision, just cutting it out from the inside, offers the same outcome as removal of the entire rectum. But you can imagine the difference in morbidity. So this operation, the patient, it takes me about a half hour, and you'll watch one of them right now. It's abbreviated into about 30 seconds. And we do the procedure, we cut it out, we sew it closed. The patient goes home the same day, and generally speaking, about 3 or 4 days later, they've forgotten they've had surgery. And as long as you're choosing the right patients, that's the way to go. And Mike is a great story because he was consented to have his entire rectum removed and have a colostomy. And so this is what he had instead. Is we go in, that's my right and my left hand. There's the lesion there. It is an early stage rectal cancer. It's a T1 rectal cancer. This is the process of me cutting it out. And when I cut it out, I'm literally putting a hole in the rectum. And if you look, color's not great, but you can see that sort of fat underneath. You can see it's sort of yellow there in the depth. That's the fat that surrounds the rectum. Like we've put a complete hole in the rectum, and we remove this completely. Out it comes. We sew that hole closed. That's what we're doing there with the two hands. This is the suture being secured. It's closed. That's where it used to be, and that's the end of the story. Like I said, the operation takes us about 20 minutes, half an hour now, and it's removed. The pathology came back as a T1 rectal cancer that has, probably in the sort of 2 to 3% chance of recurrence, and that's the end of the story. And in Mike's case, I got skipped through a bunch of the stuff. There he is there. I had surgery on Friday. On Monday, I went for a 5-kilometer walk. So this was Mike's story, and it's a good story because the principles are really, really important. I like this data in 2012. Average length of stay in hospital after colorectal cancer was 8 days, and average return to work was 27 days. In 2024, 1.7 days, and return to work in 2 weeks. There's a huge difference in how we're doing these operations now. I do want to really quickly talk about robotic surgery and just ensuring that everyone sort of understands the robot is really no different than the laparoscopic approach. It's very different for me because this is me in the operating. This isn't actually me, but in this case, this would be me sitting in a console. The patient is here, the ports are in place, and I'm basically driving these instruments as opposed to holding them myself and working it manually. And so robotic surgery offers a 3D, far more sort of kind of precise approach, but generally speaking, the outcomes have shown that it's the same as laparoscopy. Return to work's the same, incisions are the same, but again, it's the right operation and the right patient. And my last point that I really want to make is this sentence here, which I really am very, very I repeat it a lot, and no resident leaves my rotation without repeating it themselves. Minimally invasive surgery is not a technique. It's not synonymous with laparoscopy. It's not synonymous with robotics. Minimally invasive surgery is a philosophy of care. So in my 97-year-old, the most minimally invasive technique was a small open incision for 4 inches. And I say to the residents, because they've all seen maximally invasive laparoscopic surgery. Laparoscopic surgery that lasted 8 hours when it could have been done in an hour and a half if it was open. The minimally invasive surgery is not just picking one technique. It is the ability to choose the right tool out of your tool belt for the right patient and the right tumor. And that the necessity of that is to have a tool belt that's full and that is evidence-based, and that you have been, and I won't get into the rigorous sort of process of making sure that each one of these, like you can't do robotic surgery until you've trained in it properly and you can have it, but then it enters your tool belt. Same with TAMIS, same with laparoscopy, same with everything. And so it behooves the patient to ensure that they're getting the best option, and that it's not about the surgeon, it's about the patient. So I'll stop there. It's 11:32, so I'm just over.
That was absolutely fantastic, Dr. Ashamalla. Thank you so very much for, for bringing your passion and your expertise and sharing it with not only our colorectal cancer coaches, but also the broader community today. We're incredibly grateful for that.
My pleasure. My pleasure.
What we'll do now is we'll go behind the scenes with our coaches so we can have an interactive discussion and make sure our coaches have the opportunity to ask you any questions that they may have. For our audience members, this session will end. We are going into a health break, so we will be back at 12 o'clock with our next session on ostomy care and management, well timed. Just a reminder to please go back to the lobby in your browser to be able to enter the next session at 12 o'clock. Dr. Ashamalla and coaches, we can head backstage now.